couple of months with the very real challenges that they have experienced in terms of patient demand, patient acuity, ambulance handovers, boarding, and all of the other practical things that they've had to cope with. We've had a long discussion led by Lucy this morning, and I just want to put on record the board's, again, enormous thanks to all of our frontline teams. The second is to publicly recognise and frankly apologise to our citizens who maybe haven't had the level of service that they would normally expect from their NHS and social care colleagues over the last 6 weeks or so. It has, as has been indicated in the press, been an unbelievably challenging time. And we apologise for the fact that despite, as I said, the phenomenal efforts of frontline teams, things have not been as we would like them to be and not what we would expect. But I can assure the citizens of Hereford that there is a real plan and momentum to getting back to the service standards that we expect of ourselves. With that having been said, I do want to celebrate our Going the Extra Mile Award winners for January 2023. And so we have an Employee of the Month and a Team of the Month. Could I ask colleagues to make sure they're on mute, please? So the Employee of the Month is Laura Samuel, a dietitian. I don't think Laura's on the call with us, but what I will do is I'll read out the commendation to Laura. The nominator said, Laura is always doing great work. She involves both parents and patients in useful and practical ways. She's designed an education programme for the paediatric diabetic patients for the whole year. She's also been involved in designing and implementing useful workshops and study days for this group of patients when they move on to secondary school to help them prepare for this big change. Laura recently arranged a fun outing for the children and young people with diabetes. She took them for a walk, showed them King Arthur's cave. Laura, at some point, I'd like you to show me King Arthur's cave as well. They had a barbecue and then did archery. Needless to say, they absolutely had a ball of a time. There was also a good opportunity for them to meet each other, to see that they and others are in the same boat, to learn that they can still enjoy life despite having diabetes. Laura also organised the funding for this event. I definitely feel Laura is not only doing excellent work on a daily basis, she goes beyond that. This trust and the paediatric diabetes team is lucky to have her. Laura Samuel, on behalf of the board, thank you very much. You're our Going the Extra Mile Employee of the Month. Then we've got our Team of the Month, and I think we've got some colleagues on the line from the outpatient nursing team. So thank you for joining us. So the nominator wrote, the outpatient nursing team in Oxford Suite, Fred Bulmer and ENT are a committed, flexible, hard-working team who are going the extra mile every day to support patients' journeys while in outpatients. A few examples are they are fully engaged with the management of change to support evening and weekend working. Staff are also volunteering at weekends outside their hours to support additional sessions to reduce waiting times. Staff often stay late, waiting with patients for transport or admissions. They're engaging with the patient transformation team, coming up with some great ideas to improve the outpatients. They support patients with all their needs in a caring, compassionate way. They're volunteering to undertake additional training. Every morning at their huddle, they come into work for the day, engaged and keen to make a difference to patients. They're engaging with the sisters and junior sisters to support the service. And this team should be commended on their flexibility and support with working additional weekends to ensure the additional sessions go ahead and their commitment to ensuring every patient has a good experience. So on behalf of the whole board, the outpatient nursing team, a big round of applause. Now, a couple of other things I want to mention before we get into the main business is I want to welcome Andrew Parker as our officially joined coup Chief Operating Officer. Andrew went through a pretty substantial recruitment process, which I'm sure wasn't enjoyable all the time, Andrew. But we're absolutely delighted to have you join us in a sort of a complete capacity rather than the interim capacity that you have been. So big round of applause to Andrew. And finally, I want to welcome Chris Lewinsky again to our board meetings. Chris, we've missed you during the COVID period. It's wonderful to have you with us again, and look forward to your contributions, which we will no doubt come back to later. So I will get back to the main agenda and just check that are there any apologies for absence? I don't think there are. Declarations of interest. Any new declarations of interest? Please raise a digital hand. Okay, thank you. The minutes of the meeting held on the 1st of December. If you weren't happy with any aspect of those minutes, could you please raise a digital hand? Okay, can't see any hands raised, so I'll take those as accurate. So we'll go then to the matters arising on page 21 of our pack. And the first was for Jeffrey and Katie to present a report on the work being carried out on the changes to the numbers in our workforce. We had a big session on workforce this morning in our board workshop, but that's a specific action point has been taken account of within the performance report. And then on the finance report, future finance reports will include details about how the trust benchmark compare regarding their finances to other trusts, and we'll come back to that in the future. So thank you for that, Katie. Are there any matters arising that I've missed? Please raise a digital hand. Okay, so keeping things moving. Glenn, your Chief Executive's report, please.
Thank you, Chairman. So, I mean, firstly, I'd like to add to what you said, actually, which is to praise the staff for what they've been able to deliver over the last few weeks, which has been an incredibly tough time. Demand has been, we've been breaking all the wrong kind of records, actually, in terms of the demand that we've seen, and the response from all of them has been brilliant. Also, the response from the exec team who've managed this incredibly well. In fact, also congratulations to them for getting a board pack out, because the other two trusts in the group, they actually had a month off, but you've obviously got a tougher managing director. It's been tough for the NHS. There's a few things I'd just like to highlight from my report. Firstly, talking about the recovery summit, which covered a range of issues linked to this matter. It was encouraging to see that it was a listening exercise, and I certainly said a few things. Also, elsewhere in the group, we saw the announcement of integration frontrunner status for Warwickshire. There's only a half a dozen of those across the country. That will give us an opportunity to test some new things, but also to try and remove some of the barriers to effective discharge of patients. So that will provide us some learning that we can implement across the whole group. There's an urgent and emergency care strategy being written. I've seen a draft of that, and I think the important thing for me on this is making sure that it moves beyond the walls of the hospital and looks at the entire system, but also looks at the entire person, rather than it being too kind of ology focused on the individual problems. And we've certainly learnt a lot in our approach around managing frailty, managing general acute medicine in a joined up way. I then refer to the planning guidance, which predictably came out on Christmas Eve. It was different this year in that it was more of a summary document and identified fewer but important priorities for the NHS. Those three tasks are set out, but then it asks systems to focus on the priorities that are identified there under those bullet points. And I won't go through all of them. Just to remind colleagues that we meet as 3 boards in early February, and actually we'll be looking at our new strategy, and our new strategy is very consistent with all of the things that are within the planning document. One thing it does do is recalibrate the A&E 4-hour standard to a standard that will be 76% as opposed to 95% that's currently written down in the NHS constitution. And the aim is that the NHS will get to that 76% before the end of the year. And we'll come back to that as we discuss some of the performance issues and later on in the meeting. Then reference to the financial framework, the headlines of which are supposedly a return to payment by results, but we've not seen the detail of this yet. So it's referenced in the planning guidance. Some more detailed finance guidance came out at the start of this week, but the devil will be in the detail of this one, because there's further information expected at the end of the month. And I've got a conversation with one of the national team later just to understand whether we really are moving to payment by results for elective, or whether there's a slightly nuanced version of that. I think it's important to use that mechanism as part of elective recovery. I think ideally in a couple of years' time, when we're in a better place, we can move to fully capitation-based allocations for places like ours. But I think payment by results will help to drive more activity in these intervening years, and we certainly need to demonstrate that we can do that. And that's obviously one of the main things that we talk about in our 3 boards together meeting, where we look at the comparative performance of all 3 organisations and see where we can learn from each other. One word of caution alongside some quite cautious numbers actually is that there's an assumption of a 2% pay settlement, and talk of, if it is higher, that will be funded, but also we hear talk of the NHS needing to improve its productivity. So I think we just need to watch out for the risk of potentially an unfunded pay award adding to the complications of trying to achieve balance next year. Then helpfully, based on some of the things I've already said, there's a really good update here from the medical division, identifying some of the things that they have been doing in response to the challenges, and that they continue to innovate, continue to recruit, continue to develop solutions like virtual wards, which are really going to help us as we move forward. And one of the things we will focus on actually in the 3 boards meeting is how we try and measure today's urgent care system. Because a lot of the measures that we traditionally use are all about face-to-face patient contacts, as opposed to some of the virtual activities, some of the advice and guidance, some of the different points of contact that go on. So trying to get under the bonnet of that in a better way will be helpful. Under the ambulatory and frailty session, it points out that we've not been able to run our frailty same-day emergency care facility, and we still are struggling with that. So when a hospital gets over full, we end up using some of that space to house patients. As soon as we can get back to a situation where we've got our functioning ambulatory capacity, the sooner it will get better overall. So that's very much a focus of the way we're managing our way through recovery following that particularly tricky period at the start of the year. And then at the end of the document, there's the employee of the month and the team of the month. So I'm happy to take any questions, Chair.
That's perfect, Glenn. And just before I invite questions or perspectives, it is, I think, a recognition of the important work you've been doing with colleagues nationally, that you were invited to the session at number 10. So on behalf of the citizens of Herefordshire, thank you for your hard work. Questions and perspectives to Glenn? Andrew?
Yeah, as Glenn knows, I feel having a direction of travel which moves away from PPI is a good idea. You mentioned the sort of role of the 3 boards just in your discussion around ensuring we're getting the most the best from our resources, if you like. And as a comment, really, I find that 3-board session really powerful, actually, in terms of us keeping an eye on what's good and implementing what's good and getting best value.
Yeah,
comment?
Thank you, Andrew. And I mean, just the difficulty in just trying to make sure we're comparing like with like has been an interesting part of that journey, which Jane has led on, and certainly the work that David Mowbray's been doing across the group at looking at medical productivity. So yeah, I agree. I think they're really powerful.
And thank you, Grace.
Thank you, Chair. Thanks for the update, Glenn. And just checking, in terms of the NHS planning guidance, what it's saying about increase in mental health provisions and people with disabilities and autism, do you know if there's going to be any increase in assessments for autism that's going to be included in that? Because obviously people can't access the services unless they know if there's an issue, and I know in the community it can be access to assessments can be such a big deal across the UK.
Yeah, thank you, Grace. Some of this will be about our kind of local response to the planning guidance, but what the planning guidance does make really clear is that there's still an absolute intention to deliver on the mental health investment standards. So ensuring that we spend more money year on year in mental health services, and then obviously we will play our part locally as the lead provider in the patch to ensure that is suitably spent in the right parts of the system. And they'll be different in different parts of the country, but we need to demonstrate actually that we will honour and ideally support even more that investment in prevention and managing people's mental health in the same way that we directly deliver some of the physical health services. But there will be proportionately more money for mental health services than others, so that gives us some ability to do that.
Okay, thank you, Grace. It was very difficult to hear you, Grace. I think Glenn was suffering from the same problem. So just so you're aware that the mic at your end is a little bit problematic. Ian?
Yeah, thank you. Good to see the announcement of the additional funding the weekend, Glenn. It's for care home beds, and obviously any money which helps reduce pressure on the hospital is welcome. Equally, of course, we know that the vast majority of people leaving hospital, we want them to go home and they want to go home. So I wondered if you just wanted to say a little bit more, or perhaps Jane, about how that additional money will support what we're already doing in Herefordshire.
Yeah, I'll let Jane come in after me, but as you say, more money is helpful. I think one of the other messages that I would give is that more money on a planned basis is helpful also. So short-term announcements are not the best way to ensure that we get best value out of that. And the best value solution is to develop a home first model. And we've got loads of evidence that demonstrates that that's not only the best thing for patients, it also works financially. So locally, we will use the flexibility that we've got with that additional money, together with our share of the 500 million that was announced in the autumn, together with Better Care Fund and other pots, to ensure that we get best value out of all of those things and do some of the things that we wanted to do. But I think one of the things I said in the session with the Prime Minister was we need to ensure that each integrated care system has a strategic plan for discharge that is suitably right-sized based on the local needs, that, you know, whenever any additional money comes, we then automatically know what we would want to do with it next, rather than thinking short term about those solutions. So I think that's something that I think we're quite advanced on. I think the work that we've done around point prevalence studies that give us a view about the need across the system have put us in a good place on that. So more money is helpful, but recurrent, clear additional streams of funding into future years will be even more helpful.
Jane, anything you want to add to that?
Yeah, just locally. I mean, I think both John and I have fed back before. I mean, we started this work in sort of September, October time, seeing what was coming, and said, let's have a set of things that we've agreed would make a difference, so that when the money inevitably comes, we can pull it off the shelf. And so we've really been doing that with partners in social care. So a range of things, from additional money into home care, the bridging service that we've put in, so that NHS healthcare assistants effectively are looking after people who need a home care. a better commissioning of discharge to assess capacity in nursing homes. There's a whole range of things that we're doing, but we started planning for it really early.
Okay, great. Thank you, Jane. And finally, David, then we'll move on. David Mowbray.
If I could just go back to Grace's question, Russell, if that's okay.
Of course.
So, Grace, Lucy and I are absolutely focused on getting the information that we need to assure ourselves that we're providing the services to autistic children that we need to be providing. The other thing I'm thinking, and forgive me if there's already a non-exec director involved in this, but I don't think there is, but I would welcome further scrutiny, Grace, from yourself on our journey with this. But yes, it's we were just at a meeting with the council yesterday when we were talking exactly about this very subject. So happy to talk to you offline.
Thank you, David. And I guess the only thing I would add, Glenn, is given the experience of the last 6 weeks for our frontline teams and our citizens, I have made a request to the Hereford and Worcester ICS system leaders that we do a post-mortem, a learning piece of work to try and minimise the risk of anything similar happening going forwards. And I know there's a lot of very good work going on at systems level to identify the systems learning so that we can share that with partners and move forward more positively. Colleagues, happy to move on to the integrated performance report. So Jane, over to you.
Thank you. I mean, probably not much to add to my written introduction this month. I mean, other than really, I've clearly highlighted the sort of unreasonable demands that have been placed on staff and some of the poor service that we've given to patients, which you've already touched on. I mean, the scale of that. We've got 300 adult beds, and we were caring for 400 patients at its very peak. So people can only imagine how difficult that is. But as we sit here today, I mean, we're still caring for 35 more people than we've got beds for. So we are a long way from out of the woods. So although we're out of that very much crisis phase, we're a long way from where we really need to be. I've just talked through, so there's a whole range of things around discharge which will continue to come online over the next few weeks, and will continue to improve the position. The other thing that we're doing is looking at what our urgent care system for Herefordshire needs to look like in the future. So the much broader approach to that. So not just the things that the hospital does. And we've made a commitment to pull together that blueprint. So that's across primary care and social care and ourselves. So to complete that blueprint, and that's work that John and Alan are leading on with all partners by the end of March. Because then that puts it in place, because the ICB are going out to recommission both GP out of hours services and 111 service. So there's quite a lot of opportunity in that. So if we're clear about exactly what we need for Herefordshire, they can make sure that they put that in that recommissioning of those services. So that's a really important piece of work which is live now, and we will bring it back to the board. And then just the last thing I wanted to touch on was really what we talked about this morning in terms of recruitment and retention. So we obviously made quite a big strategic move with that new deal for our healthcare support workers. I mean, the early indications are that is paying dividends, and those staff will see that in their January pay packet, their back pay to October from that increase in salary for an awful lot of them. And so really that is around us using the flexibilities we've got under the national pay system, so that we can train staff to a higher level and then reward that level of training and experience. So and hopefully that will help us to retain as well. And so that taking that approach to particularly our registered nurse workforce is the next step of that. And again, over the next couple of months, we expect to be able to come back with a proposal for that. So those are probably the things that I wanted to highlight before handing over to colleagues.
Okay, that's great. Thank you, Jane. Obviously, a lot of work going on. Any questions to Jane, or do we want to dive into the detail? Okay, so we'll start off then with you, Lucy and David, on quality, please.
Yeah, if I kick off and then I'll just hand over to David at the end for mortality, if that's okay. I'm going to try and be brief, but the first thing I want to talk about is flu. So we've seen a large number of flu cases in November and December, although it is starting to fall now, you'll be pleased to know. And they were all flu A cases. We've seen a couple of flu B cases in the last couple of weeks, but we do know that the vaccination's efficacious both against the flu A and flu B strains. To date, surprisingly, there has never been any national guidance for the management of flu in an acute hospital setting. There is for nursing homes and care homes, but not for acute hospitals. So in December last year, the region produced some regional principles around the management of flu in acute hospital settings. And essentially those principles covered things such as mask wearing, swabbing, isolation of patients, how you manage contacts of flu, how you step down flu positive patients, and how you manage staff returning to work following flu. For our patients, our visitors, and for the public, that meant we reintroduced mask wearing when on our premises. Our staff had already been wearing masks prior to that launch for the public and our patients. The main principle I want to talk to you about in the flu guidance is that they talk about the step down of flu positive patients and they titrate that to the pressure that the NHS is facing. So ideally, best practice says that you would isolate a flu positive case for 7 days prior to step down. The principles recognise the pressure that the NHS has been under and have a level that's level 3 that's called the extremist level that enables you to step down flu patients on day 3. And the reason I mention that is we have been operating at extremis since December the 30th and therefore have been under strict criteria and under the observation of the infection prevention team been stepping down flu cases on day 3, providing they don't have a temperature. And IPC agree to that step down. I'm pleased to say that yesterday we made a decision to move to the middle tier, which is isolating patients for 5 days prior to step down. We do know from our analysis that that's not causing harms to other patients, and there are only a very, very small minority of patients that catch flu off another patient. I want to talk about pressure ulcers very briefly. It won't be a surprise, we've talked about pressure ulcers here at board previously. We've seen an increase in the incidence of pressure ulcers, and that's avoidable pressure ulcers. That's pressure ulcers that occur in our care or deteriorate in our care. We've seen that for the last year, but we had our highest number in November of this year. Now we know we're seeing an increase in the incidence nationally, and that's been seen since the pandemic. And we know that the acuity dependency of our patients has increased in the last 12 months or so. But I also know that the pressures that we're currently facing with those 100 additional patients that Jane described, but yet with no more staff, that we are causing unnecessary harm to our patients. That said, there are green shoots of hope. So you will see in the report the community hospital sequin, which is around ensuring that patients receive the appropriate assessment of their risk of developing pressure ulcers. And you can see that the performance has improved in the last quarter, and that has also translated into a significant reduction in patients actually acquiring pressure ulcers when in our care. And we're going to roll out that methodology and approach to our acute wards in the coming weeks. Our medical director suggested only a couple of months ago that perhaps we should treat the incidence of pressure ulcers as a mortality outlier. And so we met last week, a number of senior nurses and one of them, and Christopher, our mortality lead, to just look at how we look at the data, how we analyse that, and then how we apply the improvement methodology to pressure ulcer assessment and management. And we're going to be rolling out some training, clinical practice training weeks to our clinical areas during February, and pressure ulcers will feature in that training. I'm going to take the falls report, the falls element of the report as read, but as you can see in there also, we are seeing an increase in the number of patients falling and the harm suffered by those patients. And again, we know that that's similar to pressure ulcers, multifactorial, increasing frailty, increasing dependency, post-pandemic issues, but also the pressure that we're facing currently. That said, we continue to benchmark favourably, but it is one to watch, and falls will also be a feature of those clinical practice weeks that are happening in February. And then just finally from me, in relation to falls, pressure ulcers and nutritional screening and risk assessment, we've changed the forms, so the risk assessments that sit on our electronic records, we've simplified those to enable staff to complete them more easily and therefore take the right action. And we're also working with our electronic patient record colleagues to be able to pull off a dashboard that shows how many of our patients have been assessed at any one time, which will just help our clinical staff focus in the right areas. That's all I want to say. I'm happy to take questions at the end, but I'm going to hand over to David for mortality.
Thank you, Lucy.
Thanks, Lucy. Yeah, so just briefly, Russell, it's another month of relatively good news with reduction in both our in and out of hospital mortality. We've shared our locally developed perinatal mortality school with our Swift colleagues who are keen to implement it in their hospital, which is just another demonstration of us being able to share good things across both areas. And lastly, we're progressing well towards the rollout across the whole of Herefordshire for the ME service, the medical examiner service. That means every death in Herefordshire, both in and out of hospital, will be subject to a second examination by a senior clinician. We're in the process of appointing 2 GPs to support us with that. Currently, they are secondary care clinicians, but it'll be a combination of both GPs and secondary care clinicians that will be doing this. And I think we're on the board workshop to do that in a little bit more detail in the later in the spring. And that's it for me. Thanks, Russell.
Okay, that's great. Thank you, David. Thank you, Lucy. Questions and perspectives to David or Lucy? Francis.
Thanks very much. Very comprehensive. Some worrying things, but not unexpected in the context of the situation that we've been discussing previously this meeting. So, but one thing that I have been pleased to be involved with a little bit is around a group looking at falls that's tying in with the dementia and other things. So really trying to think holistically and rather doing just the little pockets of innovation and transformation work, trying to do that more systematically. So that's obviously been slightly delayed because of operational pressures, but really keen that we tie that up and also look wider than just how it is in hospital and get really good pathways and data analysis that cross the boundaries between services, both in and out of hospital. So well done to the team for making that happen. The first thing, our responsibility is do no harm, and I think all of us really worry because people can come to some harm in our care, and that's what we're describing. So anything we can do to avoid harm is absolutely key. So keep up the good work on that.
No, you're absolutely right, Francis, and the combination of falls and pressure ulcers are 2 of the key measures to make sure that we are getting it right. Ian?
Yes, thank you. Just among all the challenges there, I wanted to pick out the good news around the nutrition screening with a real improvement from Q1 to Q2, where we're above compliance now. So just to say well done with regard to that, because that's been a challenge for us in the past.
Yeah, no, well said, Ian. And any other questions or perspectives? Okay, just to, again, to say to both Lucy and David's teams, we are, as a board, very conscious of the heroic efforts you've been putting in day out to look after the citizens of Herefordshire in a very difficult set of circumstances. So thank you very much on behalf of the board. We'll move on then to the activity performance. And Andy Parker, over to you.
Thank you, Chairman. I just want to start with just adding my thanks, like you did, to our operational and clinical teams over the last 4 to 6 weeks. It's been incredibly challenging. And as always, I'm amazed at the responsiveness of our staff and their flexibility, grit and determination to get us through and balance that risk, not just across the trust, but across the health system as well. So thank you to them. To support the staff, and I put it in my report, we've been running now for the last 4 weeks a command and control structure across the trust to help our operational teams escalate and balance those risks and support that decision making over these challenging times, with daily exec oversight across 7 days. In my report, I've highlighted some of the steps we've taken and some of the innovation that's come out as well, including how our community integrated response hub has been picking 909 calls off the ambulance command and control system stack and have been responding to calls approximately 4 or 5 a day to prevent ambulance responses and conveyances. And I mean, that's an incredible achievement there. But also, I just want to thank our system partners over this period have been, supporting us through this difficult time, attending daily silver calls across Herefordshire and Powys, unblocking power barriers and system decision making. So it really has shown how Herefordshire and Powys can pull together in these difficult times. Some of the examples of that is how primary care have increased their out of hours capacity to support direct lines for advice and guidance through to GPs for our community hospitals to support patients there, but also to increase their capacity to take direct referrals from our emergency department. So I'm thankful to those colleagues across the system and Powys. Just moving on beyond our urgent and emergency care pathways, just want to flag to the board a couple of things. So one is our cancer target. So our 28-day faster diagnosis standard, slight improvement there. We're expecting improvement again in December. Still nowhere near where it needs to be, and it is a priority for this year in terms of getting us to that 75% by March 24. But I would like to highlight the 62-day performance, which is at 80% for November, and we are at 18th across 18th in of English trusts in the sort of league table there, and it's a real credit to the teams that we've managed to continue with that cancer work over these really difficult times. In terms of our elective activity, it remains strong compared to our value-based activity against 1920, at 102% for November. But we've still got an issue with our day case activities being down, even though our overnight electives are being up, and we are still far behind our planning, our activity plans for 22-23, and we must be more robust in our planning of that going forward for 23-24, and I'm working with the operational teams to make sure that is as accurate as possible. However, our theatre productivity still remains strong, although there's much more to do. You can see in my report that we are in the top quartile now of regional trust, achieving over 80% for November, but there is still much to do. Those patients that will reach a 78-week wait by the end of March, we continue to reduce that cohort. There are some risks within that I would like to flag to the board, particularly our orthopedic inpatients, particularly with the loss of our bed base over the last 4 weeks. Although as of today, I'm pleased to report that bed base is back in operational. There is still a risk currently today with 41 patients that are undated, but I continue to work with the operational teams to ensure that we can get that to 0 by the end of March. And lastly, I would just like to flag our continued reduction in the diagnostic patients who are waiting greater than 6 weeks. Again, a tremendous effort by operational and clinical teams to reduce that risk as we move forward into this year. Thank you very much.
Andy, thank you. And I think just before I invite perspectives, a few things for citizens to fully appreciate. The first is the fantastic work that Andy and his team lead on the QI side with our so-called Transformation Tuesdays. So there's a really high level of innovation to try and ensure that we improve the way we do things and learn best practice and have a relentless approach to trying to improve our service levels. So, Andy, please continue to thank the teams for their week in, week out work to try and improve things. The second is we had a good presentation this morning on our Maxims systems and how that's rolling out to improve patient outcomes and productivity within the trust. So I think there are some real reasons to be optimistic. And I think you're absolutely right, Andy, and I just want to endorse our thanks to systems partners for everyone who's been going through a very tough time. I think I'm correct in saying that Hereford and Worcestershire are in the top 2 counties in the country in terms of face-to-face appointments with GPs, and that's a credit to our primary care colleagues. So, questions and perspectives to Andy. Please raise a digital hand. Francis.
Sorry, me again. Well done, Andy, and well done to the teams. And again, congratulations on your substantive appointment. Will we look forward to the next month's report showing an increase in day case activity? Because I understand the November position of trying to catch up on the complex inpatients, but whilst we haven't been doing as much overnight operating because of bed pressures, have we managed to plough through more day cases?
Actually, the opposite, Francis, because we've managed to ring fence a lot of our elective inpatient activity to maintain particularly our major cancer work. Our day case unit has and still does have inpatients in today, although it's much reduced. Day cases do concern me, and I am working with the teams around how we improve the productivity for our day cases. But I think the case mix post-pandemic and some of the complexity in some of those long waiting patients means our elective patients are the priority rather than our day cases currently. But we aim to improve that position.
I think I'm correct in saying, Andy, correct me if I'm wrong, that we do have as an operating principle to try and keep elective activity going. And if we do cancel an operation, it would be at the very last moment, because we're endeavouring to do as much elective work as possible. In other places, they tend to cancel elective work much earlier. And then actually, if they're able to do it, the person who might have been able to have an operation misses that chance. That is our approach, isn't it?
That's correct, Russell. We don't cancel until on the day or the very latest the night before if we see we're in a real challenging position, but we're not cancelling in advance. We're doing whatever we can to get our patients in, even at short notice.
So for those patients who we do cancel at the last moment, it may seem irritating. We apologise for it, but it is because we're trying to keep our elective work going forwards. Andy, thank you very much. We'll move on then to workforce. We had a good workforce session in our workshop this morning. So, Jeffrey, what would you like to pull out of your report?
Oh, thanks. Thanks, Russell. Well, I guess like many other energy organizations, operational pressures are still impacting on our capacity to attain our KPIs, but the HR department will still carry on supporting managers, and we're determined to try and attain those KPIs. I mean, agency expenditure is a key area of concern, as we highlighted this morning. So we're putting in place more robust systems and governance practices. And we are also developing strategies to try and see how we could convert some of those long-standing agency individuals into more substantive positions within the organization. And we will continue doing that work over the coming months. In terms of industrial action, we have pretty good relationships with our local trade union reps, and we have a working group in place. So we are ensuring that we can be as prepared as possible in the event of potential industrial action over the coming months. We will continue working with managers to try and reduce sickness absence and also enhancing the health and well-being of our employees. And as I mentioned already, we're determined to reduce agency spend and address our recruitment and retention challenges. So lots of work going in the background, as we covered, during the workshop this morning. And happy to take any questions, Russell. Those are some of the key highlights from the report.
Thank you, Jeffrey. Questions and perspectives to Jeffrey? Andrew.
Yeah, I welcome the more robust governance practices agency. I think they will have some effect. But in the end, I'm sure you know this, the solution is in recruitment, isn't it, and retention, that we need to bring the establishment and the actual number of staff closer together. That's so I don't, yeah, it's just really a comment, really, I think.
Observation well made, Andrew.
Observation, yeah.
Okay, thank you. Okay, Jeffrey. So we'll move on then to Katie. Katie, obviously, with some of the challenges in terms of sickness and acuity of patients, some real challenges on agency costs, as Jeffrey's indicated, but tell us about the money.
Chair, I've just had a message from Katie. Her Teams has crashed. She's trying to rejoin.
Okay, so perfect timing there, Katie. So we'll come back to Katie in a little while. Amazing what executives will do to sort of raise their head above the pulpit in public board meetings. So we move on then to the CSNT 10 self-assessment. Lucy, do you want to introduce this, and we'll come back to Katie a bit later?
Yeah, no problem, Chair. Thank you very much. So just for colleagues' awareness, this is year 4 of the CNST 10 scheme, and we're required to submit a self-declaration against the 10 standards that link to that scheme and submit that to NHS resolution early in February. What full compliance means for the organisation is that it enables us to recover just short of £150,000 of our contribution to the clinical negligence schemes. Submission to the NHS resolution requires sign-off by our Chief Executive, and additionally this year it also requires sign-off by the ICB Accountable Officer. In order for board to be happy to sign off that declaration, you have to be assured that the evidence exists and that our self-assessment is accurate. And the way that we do this is you're required, to have a peer review of your evidence in order to provide that assurance to the board. So we asked our local maternity and neonatal system to undertake a review of the evidence towards the back end of last year, and as you'll see in the report, they've done that for 9 out of the 10 standards and agree with our self-assessed position, and we thank our colleagues for doing that. You'll see in the report we're asking board to delegate responsibility for standard 3, which is the outstanding standard that we're yet to have fully assessed by the local maternity and neonatal system. We submitted some evidence, they have reviewed that, and they asked for some further evidence, which we have submitted, and they are reviewing that and will feed back to us tomorrow. We have a face-to-face meeting with the local maternity and neonatal system tomorrow, and what we're asking board to do is delegate anything that comes out of that final review by the LMNS to Francis as the maternity safety non-exec board member, myself as the executive board member, and Jane Ives as managing director. So we just need a steer from board if you're happy to delegate that responsibility to us. And clearly Amy's here as our Associate Director of Midwifery, who's led this piece of work on behalf of Wye Valley Trust. I know her and her team have worked exceptionally hard. She's here to add anything to this that I haven't said, and also to answer any questions that board would like answering in order to feel satisfied that we can submit that declaration in line with the national deadline. Thank you.
Thank you, Lucy. Amy, is there anything you'd like to add?
I think Lucy's covered much of it. I just sort of wanted to touch on, obviously, taking the report as read, but just bearing in mind the nature of CNST is quite complex, and so not everybody may be able to understand fully all of the work in its entirety. So happy to, you know, take any specific questions and be able to respond to those. And I think was just to highlight that whilst in some ways this is, you know, implementing this has been it sounds very simplified in terms of the report, 10 standards, we undertake the actions, tick the box, wow. It actually is, you know, a really complex, laborious requirement. That said, this doesn't detract from the impact of achieving the standards that we know that successful implementation will lead to safer services and improved outcomes for women and their babies and families. So to some extent, I would ask really that this, even if we don't agree the final one, I think actually to get to 9 and to have had that approval from the LMS is a celebration and a testament to the improvements to safety that have been made in the service. And then just to highlight that much of this work was embedded in practice. This has been a 4-year scheme. It's been embedded by my predecessors, teams of old, as well as obviously the current teams who have laid and paved the path for the success of achieving the current position. And, you know, just wanted to thank those. And then just any specific questions.
Thank you, Amy. Any questions or perspectives to Amy or Lucy? Francis?
I've been, for board assurance, I've been intimately involved with this, not doing the enormous amount of legwork that Amy and Lucy and the teams have done, but it is, I think that I've been very assured by the rigour that the team have applied to doing the right thing, and the simplified, very accessible report that I think we have in front of us today is condensed from very, very, very detailed metrics and reams of evidence that go behind it. So it is a very robust process, and we, Lucy and I, have together with Amy been pushing to be as more critical of ourselves than we'd expect someone else to be of us to do the right thing. So would definitely support all that Lucy and Amy have said.
No, thank you, Francis. And I think that's exactly the sort of perspective that we should take. Let's be more critical of ourselves than others would be. Ian?
Yeah, just to acknowledge, Chair, it's a slightly frustrating report because obviously what we would have wanted is for this report to give us a clear position statement, and as Chair of Quality Committee, we've considered this twice in November and December, and I was hopeful we would have got this over the line before clearly it came to board today. But just to support the recommendation there is being made, I think in a sense we are where we are. Hopefully we can reconcile what needs to be reconciled in the meeting tomorrow, and also to say that notwithstanding there's a financial benefit to getting the 10 standards, the important thing is actually that we've got agreement that we meet the standards, that we know we meet the standards, and actually that we've got support from the ICB in that regard as well. And clearly that needs to drive us rather than the financial dimension. So a little bit frustrating, but we are where we are, Chair, and I would support the recommendation.
No, well said on the point on finances, Ian. As you've often heard me say, the two most important things we do as a trust is to bring life safely into the world and to allow life to leave the world with dignity. So we do this for the formal reasons about bringing life safely into the world, that the money is a helpful but not primary consequence. Amy, is there anything you wanted to add?
Just to say thank you, and I think just to acknowledge that the delays really are in part due to the change of leadership in the LMS, which has been very recent, and actually the oversight that the LMS requires with a new leader just has led to a little bit of back and forth in terms of providing assurance and evidence. So some of those things, you know, are also the frustrations are felt by me as well, Ian, but hopefully we will solution those before the end of the week. Thank you.
No, thank you, Amy. Lucy, in terms of the delegated authority, I would just like for Ian to be involved as Chair of Quality Assurance, to be involved in that delegated authority. I can see you nodding at that. You're happy with that?
Absolutely.
So on that basis that we're giving delegated authority, but we're involving the chair of the Quality Assurance Committee, is everyone happy to sign off on the CNST 10 self-assessment on that basis? If you're not happy, please raise a digital hand. Okay, delegated authority duly given. Thank you, Amy. And Amy, please send the board's thanks to all of our maternity team for their hard work day in, day out. So they do a great job for us, so thank you. So we'll move backwards then with hopefully the arrival of Katie after her strategic exit to tell us that despite the challenges we're having on agency and elective, how are the numbers looking, Katie?
Thank you, Chair, and apologies. Teams chose a very inopportune moment to just shut down on me with no warning, but I've restarted, so hopefully it will now survive. In terms of the numbers then at month 8, so that was year to date to the end of November, we'd remained broadly on plan in the month of November, and therefore on a year to date basis remained slightly worse than the planned deficit year to date, with a total deficit of £4.74 million. You'll recall we talked last month around what that looks like therefore as we move towards the end of the financial year, and whilst we felt it remained challenging, we felt it was realistic that we would still remain in line with our plan by year-end outturn. That's the position that we are holding. We've got a series of mitigations in place to manage some of that financial risk that we know we face over the latter part of the year. Clearly, in light of the discussions we've had today around how challenging the last 4 to 6 weeks have been, the level of financial risk within that does continue to increase, and particularly driven by high agency spend in the sort of December-January period that we will expect to see feed through future months' numbers. So not without challenge, but we're holding the year-end forecast at plan. In terms of CPIP, delivery has remained relatively static this month. So this is our cost efficiencies, how we try to make sure we deliver our productivity and cost improvement benefits over the course of the year. And we're forecasting delivery of £8.4 million worth of improvement in the year, which isn't insignificant. So it's a big effort by our teams, but unfortunately not enough of that is delivered through recurrent schemes that will continue to drive a benefit into next year. And so our focus now is heavily on operational planning, understanding the guidance that's been published and really driving those and that identification and planning for delivery of a greater level of improvement into next financial year. From an overall system perspective, so picking up the action for sort of future reporting around how do we benchmark to others, as an overall system for Herefordshire and Worcestershire at the end of month 8, we were reporting an adverse variance to plan of around about £4.5 million, but again committing to delivering the full plan by year end. And in overall terms, we know the national picture remains challenging. So we're not an outlier, is my point in making that update. In terms of capital and cash, we continue to manage a challenging funding level from a capital perspective, although we have recently had confirmation of some additional funding in this financial year linked to digital and some of the clinical diagnostics pieces of equipment primarily. And our cash balances remain stable. So in summary, no material movements from a November position, some risks still remaining towards the end of the year, and a really clear focus on 23-24 now. Thanks, Chair.
Thank you, Katie, and thank you for making the financial update so clear and straightforward. You'd be amazed how complicated some chief finance officers can make the financial update. Questions and perspectives, Glenn?
Thanks, Katie. Just looking at that slide 48 of 184 of the pack, the agency spend, just a bit of time to reflect on it, because this one's so frustrating for me. If you look at the trend chart, the top left there, where we were, we'd managed to do some things to get it on track, but we're now doubling that. So we're now spending well over £500,000 a week on in those two areas, and so getting control of this and being clear of the three elements of this, the vacancy related bit, and some of this is because we've grown posts that we haven't been able to recruit to, the absence related bit, and just making sure everyone understands that we built in a level of normal absence cover in our budgets that doesn't always need to be pursued by agency. And then the kind of extra capacity bit that we've obviously faced over the last few weeks, really, those two programs, the MARP and the NARP programs, are really important in trying to get back some control because as well as the cost impact, there's the quality impact of having people in the organisation who aren't so familiar with it. We don't want to get to a situation where they are so familiar with it because they're working with us all the time. We want people to be working within the organisation, and for any members of the public listening, the development opportunities, the leadership opportunities, the research opportunities that come from being a substantive member of the team really do need to be emphasised. So this one's one that we need to keep working on.
No, absolutely, Glenn. And Nicola?
Oh yes, this is my third year looking at the finances as an ed, and they always get harder year on year. So I'm always amazed, to be honest. But so thank you, Katie. You do manage to make what is incredibly difficult look a little bit simpler, if not as simple as we'd probably all like. But I suppose looking at them this year compared to previous years when we've had COVID funding, there just seems there's more what ifs and there's more are you sures, especially when we're talking about potential clawbacks and potential full, I suppose, UK related issues that are they going to sort of look at from a national perspective. And I suppose it feels like as if now we're in month 8 that is now starting to get very squeaky towards year end and going to be even more difficult in going to 2023. So I think, but thank you for presenting it away, which is certainly a little bit easier to look at. Thank you.
No, well said. Thank you, Nicola. Any other questions? Otherwise, we'll move on. So just picking up the pace a little bit, we've got items for noting and information. The first is the CQC inspection and action plan. Lucy?
Yeah, I can be very brief on this. So as board knew last time, we'd received our draft report from following the CQC inspection that was undertaken in October. That final report was published in December 2021 and is included in the papers with the associated action plan. We were required to submit that action plan to the CQC by the 12th of January, and we complied with that deadline, and they have confirmed receipt. Just to recap for board, because it's worth celebrating, so the inspection was a focused inspection for surgery and medicine around the safety domain for surgery and medicine, and then the well-led domain for surgery. It followed the Section 29A warning notice that we'd received back in the full inspection during 2019. Really pleasing to note that the inadequate ratings for surgery were lifted to requires improvement, and is a testament to the hard work of the clinical and operational management teams within the surgical division. Pleasing to note that a very limited number of regulatory requirements, so they're the must-dos that are contained within the report, and then also just a handful of should-dos. The action plan addresses all of those. What's really pleasing to note is that many of those were limited to limited findings by the CQC during their inspection, and we just need to satisfy ourselves that those limited findings don't extend across the board, and we can do that through routine auditing that we already undertake. And those more major concerns are things that we're already focused on, so VTE, for example, the Mental Capacity Act, deprivation of liberty safeguards, our quality priorities and areas of focus. Given that, my suggestion is that the ongoing management of the action plan can essentially be through our business as usual structures. And I'm just seeking approval really from board today to delegate the responsibility for oversight for the overall plan to quality committee. And I don't actually think it needs to go there on a monthly basis. And I would suggest with board's guidance that we either do that on a bi-monthly or quarterly basis through to quality committee, given those limited number of actions. And some of them have got sort of future deadlines because they're about systematic solutions to improvement.
Okay, thank you, Lucy. Just before I open it up, Ian, would you be happy for that to be going through QAC?
Yeah, that'd be fine, Chair.
And what would your preferred cycle be, bi-monthly or quarterly?
Quarterly, Lucy?
Okay, nods from Lucy, so we'll come back to that. So questions and perspectives on the paper, and then I'll come back to that delegated authority point in a moment. Jane?
Not really in relation to the paper, other than to say, I mean, colleagues will be who've got long memories will remember that we had a series of undertakings from NHS improvement, which were related both to the CQC and some long waiting times for our elective waiting lists and those sorts of things. The last piece of the jigsaw to come into place was this, and that means that all of those undertakings have now been withdrawn by NHSE, who now take the responsibility that NHSI used to have. So it was just good news, really. We're no longer in the formal undertakings, and this is the last piece of the jigsaw.
Okay, great. Thank you, Jane. And Ian?
Yeah, thank you. It's diving into the detail a little bit, and just wanted to pick up one point on the action plan around falls risks assessment, because I note that the action plan, there's a phrase in there about the timescale is dependent on a third party, which I think is referring to a systems issue to do with maxims, but I may be wrong, which just seemed a bit of too open-ended a timescale, and I wondered what we were doing to. Well, first of all, have I got that right? But is there a way we can deal with that in terms of the appropriate priority being given to that systems development if it is about maxims? And if I've sprung that on you unfairly, Lucy, I could see you looking for the reference now. I apologise, and we could pick it up later, but it's on page 110 of my pack. It's the third row down in the action plan.
Yeah, so sorry, it's probably the action plan's a little misleading, Ian. So we can do the periodic auditing. So we do monthly auditing of falls risk assessment compliance, but that's on a random sample basis, and that's undertaken manually. So we're doing that now. That timescale's not. We do that routinely. The timescale bit is dependent on Maxims being able to produce that dashboard that I alluded to earlier, that would be able to tell us how many of our patients have had a risk assessment done as a matter of routine to prevent the manual audit from having to take place, if that makes sense. So
it doesn't prevent us being compliant. It just means we don't have the automated dashboard that ideally we would like.
Absolutely.
Okay, perhaps we just need to make that a bit clear in the action plan. Thank you.
I can. Thank you.
Okay, any other questions on this? So are we all happy to note and give delegated authority as requested? If you're not, please raise a digital hand. So thank you, Ian, for being willing to see that through QUAC going forward. So we'll then go on to the workforce and organisation development strategy. Over to you, Jeffrey.
Well, thanks, Russell. This is really just a quarterly update on what we're doing in terms of the HR and OD strategy. So if you recall, over the last few months, every quarter, I just present an update. So the paper just highlights some of the things we've been doing, and a number of the things in there we covered during the workshop this morning, but just gives an overview on what we're doing in terms of recruitment, retention, health and well-being, ADI, so the whole variety of schemes we have in place in terms of being recognized as a good model employer of choice. So it's just really an update on that, and happy to take any questions.
Thank you, Jeffrey. Any questions or perspectives to Jeffrey? Nicola?
Yeah, Jeffrey, thank you. I was just looking through the action plan and the RAG rating, and I just had a few questions, because I think we spent lots of time on this today. I'm really conscious of that, and I think it's been really valuable. I mean, this has got to be, you know, the place we are, isn't it? But I was just interested, what makes it amber or green, and it's not clear on what either the quality implementation or the quantity of what is a lot of things to do in each of the boxes was my one part. And also at Audit Committee back in December, we had a really good internal audit on effective recruitment and retention. And I just wanted to check that all the actions that were in there, and Daniela had a lot of actions taken away from that, are they incorporated into this plan, or are we running them separately?
No, they are definitely incorporated into the plan. Nicola, for instance, the things we talked about, attract recruitment, and the things we're trying to do to speed up recruitment, absolutely, they incorporate into the plan. And a lot of the actions are still amber because we've still got a long way to go. I mean, for instance, we're talking about the recruitment and retention challenges we have from an EDI perspective, from a health and well-being perspective. So that's how we do the assessments in terms of there's still a lot of actions for us to implement over the coming months. So at this period in time, we feel that we're actually amber. So hence why we've put those ratings on there, because it's work in progress, but we believe that we're on the right track in terms of some of the things we're doing.
So if it's green, does that mean it's completely done and we're really happy with the implementation and the quality is at the level that we want it?
That's the intention. Yeah,
Right.
that's the intention.
Thanks, Jeffrey. Thanks, Nicola and Frank.
Yeah, we've talked about this before, Jeffrey. Great report. It's got so much in it and so much work going on. But there's a lot of investment going on in the community to promote Herefordshire as a great place to work and invest. And we're asking people to move here, work here, invest their family here. And I think I can't see any reference to aligning ourselves with all that work, which is about to increase significantly, with a view to embodying some of the materials in our own promotional work and just generally aligning with it as a promote Herefordshire thing. I just think it would be helpful. Thank you.
Yeah. I'll let Jane comment. I think Jane will answer that.
Jane?
Yeah, thanks. I think we can add it as a line into the report. So there's two things that are happening. One is as part of our One Herefordshire partnership, we've had a focus on this as having a sort of a single place to come and access all of the things that are a good reason to come and live and work in Herefordshire. So we're doing that directly with partners, but also I'm part of a group that Paul Walker at the Chief Exec of the Council leads of public sector leaders, and we've also linked into that so that single place to come and look at employment opportunities also relates to fire service, police service, education, all of those other things. So there is quite a lot of work going on with that, Frank, and we are linked into all of it.
Yeah, I'm a director of the new destination bid, which I did announce some time ago, and we're about to spend, once they've sorted out a few glitches, best part of £500,000 a year promoting Herefordshire. And it just seems to me we should all be aware of one another's needs and make sure they're dovetailed. Thanks.
Yeah, no, point well made. Thank you, Frank. Okay, colleagues, are we happy to move on? Thank you. And thank you, Jeffrey, in particular. The staffing report. Lucy, what would you care to pull out? Because we've been talking about that a lot today.
I do. So apologies for talking such a lot, and apologies again for asking for permission to do something different moving forward. But so I'm going to take the staffing report as read. And when I was writing it, I thought, gosh, there's little point in talking to board about the November staffing position at a meeting in January when actually the whole staffing situation is in a completely different place today than it was in November. So that's why I'm going to take the report as read, but focus really on the 3 paragraphs at the bottom of the first page, which is about the current position. So, you know, Jane alluded to these 100 extra patients that we've had in our bed base sort of throughout this very difficult high pressured period. And during that time, as I alluded to earlier, we've had high cases of flu amongst our patients and in our beds, but also amongst our staff. So sickness rose for registered nurses, healthcare assistants and other professional groups. We had those additional patients, but no more staff to look after them. In fact, we had less staff. So our agency demand went up and the agency haven't been able to meet that demand. So there've been many shifts not filled, and our Thornbury usage has gone through the roof in the last month, and that will clearly impact on our financial position as well. So the main message from the staffing report is that we're in a really tough position. It's getting a little bit better, but we're not out of the woods yet. What I want to seek permission from board to do, given that we now meet every 3rd month, we meet as a tri-board rather than just the Wye Valley Trust Board, is that we'll always be in a position where we're talking about quite old information. So my proposal in my executive summary really is to try to continue to meet the National Quality Board requirements for board reporting about staffing, but to suggest a sort of easier and simpler proposal moving forward. So my proposal is that we continue to produce a monthly report for the Quality Committee that does the detail, and that we include the fill rate report, which is the National Quality Board requirement, in the quality indicators report that comes to board with a high level narrative around that. and that we deal with the consequence of temporary workforce, so that financial position agency spend, in the new agency reports that are going to be coming through to board anyway as a separate report. And then we would continue on a biannual basis to do that deep dive into nursing establishments that we're required to do, where we look at our staffing establishments in the context of patient case mix. So happy to take any questions and also to seek permission from the board to deal with the staffing reporting requirements in that way in the future.
Jane, does that have your support as a proposal?
Yeah, very much so.
And Katie, as the Chief Finance Officer, does it have your support in terms of control?
Yes, because the key indicators are still visible on a routine basis.
Thanks. And Glenn, you're happy?
Yes, I am, Chairman.
So just on those points that Lucy's raised at the end, if you're not happy to approve that change, please raise a digital hand. So that's duly approved, Lucy. And just general questions on the staffing report, please raise a digital hand. I would like to make a general point about Thornbury and high cost agency. To those who run those organisations, please work more strategically with NHS partners. It is costing the NHS many millions. This year, the Hereford and Worcester ICS will spend close to £80 million on agency cost, which represents a leakage to the NHS of about 20 million, which means taxpayers are losing 20 million, or our citizens in terms of healthcare delivery are losing 20 million. I'd really encourage these agencies to work more closely with us going forwards. David, did you want to add to that point?
Yeah, just a query, Russell, actually. Is it possible to legislate? Because it's the only way that I can see that we will be able to control this without actually training twice as many doctors and nurses, which will take us 10 years to go there. But I don't know if it is or not. But I noticed the government's just mentioned it recently. I think NHSE has just mentioned the costs of agency, but it's been on my mind for many years.
It's been on my mind for many years as well, David, so we're in the same boat on that. Legislation is beyond my pay grade and competence level, but I think there is a world of unintended consequences, as you see when you try and do various different things. Nicola's just pointed in the chat box, I think, to energy companies. So it's never as straightforward as you would hope it to be. And Glenn?
Of course, you can legislate for anything, can't you? But the amount of time it can take, and as Russell says, the unintended consequences can be a bit of a problem. But I think the focus for me would be on how we make it more attractive to remain as employees of the NHS. Now, whether that's through some tie-in to supporting their training costs, whether that's about the opportunities for advancement and research and training and development. But I think we could create more of a hook that legitimately, as the organisations who've invested in the training of all of these staff.
Yeah, no, absolutely. Okay, team, we'll move on. Thank you, Lucy. And if we can just sort of rattle through the committee's summary reports. The Audit Committee of the 8th of December. Nicola, anything you want to add?
No, nothing to add to that.
Thank you, and thank you for your work in it. Any questions to Nicola on the 8th of December Audit Committee? Thank you. The 15th of December Charity Trustee Committee. Frank, anything you'd like to add?
No, thank you, Chair.
Any questions to Frank on the Charity Trustee meeting of the 15th of December? Integrated Care Executive of the 14th of November. Francis, anything you'd like to add?
No, thank you, Chairman.
Any questions to Francis on that meeting? When's the next ICE meeting, Francis?
3 weeks. It was last Monday, but really positive discussions with the One Herefordshire Partnership about the future role of ICE and some of the delegations that might be possible to Herefordshire's place and Wye Valley as the lead provider.
Okay, super. That sounds very optimistic. The Quality Committee of the 27th of October and 24th of November. Ian, anything you'd like to add?
Nothing to add, Chair.
Any questions to Ian? Okay, then we just got some audit committee, some committee minutes. The audit committee of the 5th of September. Nicola, anything you want to add?
I wasn't the chair at that meeting. That was still Andrew.
Okay, Andrew, anything
Pass it back.
to add?
Nothing to add.
What a good tennis player you must make, Nicola. Thank you, Andrew. Any questions to Andrew on the 5th of September meeting? Charity trustee meeting of the 15th of September. Frank, anything you'd like to add?
No, thank you.
Any questions from colleagues? And the Quality Committee of the 29th of September and the 27th of October. Ian, you can't avoid the 29th of September. Any questions to Ian? Okay, thank you, Ian. So I think then we're on to any other business. If you've got any other business, please raise a digital hand. So I understand Chris has not only joined us today, but has also submitted a question. Great that you've been able to do that, Chris. Erica, do you want to read out Chris's question for us, please? Erica, are you there? If you're talking, Erica, I can't hear you.
She's also had a Teams problem, so it's just dropped off.
Sorry, Chair,
Okay.
I've only just reconnected. Could you repeat the question, please?
That's okay, Erica. What's the population of Zanzibar? No, the question was, could you please read out the public question from Chris?
Yes, the question is, adequate medical staffing is a problem for WVT and most other NHS trusts. There seems to be a reliance on employing more international staff and less emphasis on training homegrown staff. Many people feel this to be an unsustainable and unsatisfactory approach. Locally, Worcester University has the expertise to train both nurses and doctors. However, I believe that central government will not provide them with sufficient funding to run suitable courses. Is the WVT board supporting efforts to reverse this situation, and if so, how?
Okay, thank you, Chris. Wide-ranging discussion. Great to have you back, as I said. Glenn, do you want to lead off on this?
Yeah, very, very happy to. We are 100% behind the plans of the university to extend into medical, to be a medical school, but also to do as much as they possibly can on nurse training. And we hope certainly on the medical school there'll be some positive news on that soon. Firstly, they have to get GMC registration. Secondly, they are then seeking training numbers from the national allocation, and there's also a national discussion going on about further increases to that. We are waiting a national workforce strategy. We have been for a little while now, and that would be really helpful in framing that and setting out an ambition to train more doctors, nurses, and all other clinical professions. On the nurse training front, the challenge for us though will be being able to support student nurses as well as the pure headcount of additional numbers that can go through training, because to do this properly, we need to ensure that we give adequate support from our teams to ensure that they have a good experience with us and come back as qualified nurses. But we're up for that also, and I think one of the things that we can do, unlike many other trusts, is offer that ability to work in hospital and out of hospital. And to get that more rounded experience, particularly our partnership with primary care colleagues as well, to make that a kind of full experience to develop the future nurses that we want, that are going to be more holistic in their approach. But yeah, we will continue to take every opportunity to flag this with national colleagues, and hopefully we've got some more progress to announce soon on that.
Okay, great. Thank you, Glenn, and thanks for the question, Chris. The next time we as a board meet is on the 2nd of March, but Chris and other members of the public may be interested that we now meet as part of a Foundation Group 3 board meetings every 3 months, and the next one is on the 1st of February. Details will be available on the website on how to join us, but you're very welcome to join us at that meeting, where we compare and contrast and learn from one another in terms of the 3 different parts of the Foundation Group of Wye Valley, Swift and George Eliot. In the meantime, can I again just reiterate what I said at the start of this meeting, which is enormous thanks to the executive of Wye Valley, to all of the frontline teams for their phenomenal efforts in very, very difficult circumstances, and our recognition and apology to citizens and patients for the challenges they may have had in accessing services. Take care, everyone. Look forward to seeing you next time. For executive and non-executive colleagues, I suggest a 10-minute break, then into the confidential board. So see you soon. Thank you.